I'm Dr. Leslie Wong. I'm the director of the End-Stage Renal Disease Program and the head of home dialysis at the Glickman Urological and Kidney Institute at the Cleveland Clinic. Today's presentation is entitled Drain Pain During Peritoneal Dialysis. This program is sponsored by and on behalf of Baxter Healthcare Corporation. I am contracted by Baxter Healthcare Corporation to present this information on Baxter's behalf. Drain pain is a frequently encountered non-infectious complication of peritoneal dialysis. This module will review the clinical presentation, etiology, and management of this condition. Drain pain can be defined as a sense of abdominal discomfort arising during the drain phase of a peritoneal dialysis exchange and has been described in patients performing manual or cycler-assisted exchanges. Drain pain can be described in a variety of ways with a more acute sensation of pain or a crampy discomfort. Drain pain has been described for decades and has been a common complaint in patients on peritoneal dialysis. Pain during the drain phase can be attributed to contact between the peritoneal membrane and the catheter during the drain when negative pressure is applied to the catheter that may be malpositioned or interfacing with abdominal adhesions or omentum. Peritoneal dialysis-related drain pain can be caused by irritation of the peritoneal lining that may be exacerbated by constipation, suboptimal catheter position, or catheter-related discomfort exacerbated by improper APD-related cycler drain settings. Constipation has been a long-known cause of drain disturbances in peritoneal dialysis. Here are the steps for the evaluation of drain pain. Evaluate for constipation by clinical history. Empiric bowel cleansing if constipation is suspected. If drain pain persists, consider abdominal X-ray to document position of the distal catheter and to check for degree of residual constipation or a distended bladder. X-ray clarification of catheter position can be helpful by assessing if the catheter is too deep in the abdominal cavity or it has migrated from the pelvic cavity. Besides plain abdominal X-rays to evaluate for catheter position, constipation, or bladder distension that may contribute to drain pain, other imaging studies such as CT peritonography or MRI may provide additional information on the cause of drain pain. In this image, this 45-year-old patient was evaluated for lower abdominal drain pain and adhesions were noted in the lower pelvis between the pelvis and the rectum. This was felt to be the cause of the discomfort. Pain during exchanges is a hallmark of someone that might have adhesions that are surrounding the catheter and creating a compartment that is causing the pain. Refractory drain pain may require catheter repositioning or replacement if concerns are that the distal catheter is in an unfavorable position that prevents free inflow and outflow of dialysate. Drain pain may also be attributed to improper cycler drain settings. The automated cycler devices drain dialysate to prevent increased intraperitoneal volume. This drainage of dialysate occurs during the drain phase as the cycler exerts a small negative pressure to attempt to encourage dialysate to drain out of the abdomen. The drain settings may be inappropriate in some patients, and the cycler height can affect this negative drain pressure. With the NIPD or IPD regimen, there is no fluid in the daytime period. This is called a dry day. Therefore, when the patient is connected to the cycler, the initial drain alarm should be set at 0, as there is no fluid in the abdomen to be drained. An inappropriate drain alarm would create a situation where the cycler device was searching for intra-abdominal fluid that is not there. This may cause drain pressure that contributes to drain discomfort. In the patient on APD with a long day exchange, the alarm should be set at approximately 70% of infused volume or adjusted to the patient's specific ultrafiltration expected after the long exchange. For standard dialysis solutions, there may be net reabsorption of fluid during the long day exchange. 70% of initial dwell volume could be entered to be searched for by the cycler before initiating a fill cycle, as opposed to programming the cycler to search for the entire infused long dwell volume. As mentioned, initial drain pain may occur in patients treated with automated peritoneal dialysis. At the initiation of APD, the cycler machine initiates a drain phase to drain any dialysate that the patient may be carrying during the long dwell. The drainage phase is initiated by the cycler device initiating a small negative pressure to attempt to pull or initiate fluid drainage out of the abdomen. In patients with initial drain pain, this pain may be due to negative pressure from the cycler machine. By raising the cycler in relationship to the patient, This suctioning can be reduced, and often the drain pain can be eliminated or minimized. The cycler is typically positioned even with the abdomen, but can be elevated up to 6 inches above the patient to reduce the negative pressure. Another maneuver that may be required in patients on NIPD experiencing drain pain is for the patient to do a manual fill before connecting to the cycler. This allows the cycler to drain fluid during the initial phase of APD, or the NIPD patient can be converted to APD with a long day dwell. So in review, if a patient is suspected of having drain pain due to negative pressure from the cycler height should be reviewed. Elevation or adjustment of the cycler relative to the abdomen can be considered. The patient with drain pain may also be converted to a tidal regimen in which after the initial drain, the abdomen is left with a reservoir volume and not completely emptied to prevent the terminal drain phase. Due to the reservoir volume that remains in the abdomen during most tidal exchanges, this regimen may reduce cycler alarms and reduce drain discomfort as the fluid is not fully drained until the final exchange. In summary, drain pain is a common complaint noted in peritoneal dialysis and has been described for decades. The discomfort is attributed to the foreign body coming into contact with innervated structures during the draining of dialysate. This contact between catheter and peritoneal lining is felt to be potentiated or exacerbated by colonic distension from constipation, as the dialysate is competing for real estate within the abdominal cavity. A variety of common strategies have been used to minimize or eliminate drain pain, including laxative therapy, changes of drain alarm settings, elevation of the cycler, and tidal prescriptions. This module has briefly reviewed the clinical management of drain pain during peritoneal dialysis. For further information, please cite the references listed at the end of this presentation.